Good morning, everybody. Good morning, and thank you for coming to this morning's Grand Rounds. I have the pleasure of introducing to you Dr. Matthew Golden, our very own. Dr. Golden received his Bachelor of Arts at Grinnell College prior to moving to Johns Hopkins, where he completed a master's in public health and a medical degree. He then came to the University of Washington, where he completed his internship and medical residency in internal medicine. He then completed a fellowship in sexually transmitted disease with the CDC, followed by a fellowship here in infectious disease. Dr. Golden, now a professor in the Division of Infectious Disease, and an adjunct professor of epidemiology in the School of Public Health and Community Medicine, continues to play an active clinical role within our network. Dr. Golden's awards are numerous and include a Young Investigator Award from the American Sexually Transmitted Diseases Association, the NCHH STP Honor Award for Excellence in Innovation, and the Outstanding Investigator Award from the Western Society for Clinical Investigation. Furthermore, and not to be without mention, Dr. Golden's research and publications are vast and numerous and far too many to cite, but include well over 100 citations with articles, book reviews, chapters, and editorials. He continues to be active within the CDC as the co-chair of the STD Prevention Conference and is a member of the board of directors of the International Society for STD Research. Here locally, he is the director of the Public Health Seattle and King County HIV STD program and co-director of the UW Center for AIDS Research, Sociobehavioral and Prevention Research Corps. Please join me in welcoming Dr. Matthew Golden today as he gives his talk, New Challenges and Opportunities in HIV STD Prevention.
My microphone? Great. Well, it's always a pleasure to give a talk at Grand Rounds. It's also a little bit intimidating to give a talk about HIV and STDs at UW. We have so many people who do HIV STD research that I'm always worried I'm going to insult one of my colleagues by neglecting to mention their pathogen or their area of research. So recognize this isn't a comprehensive discussion of the topic, but is one focused on what I think are important public health issues to us in the US and particularly locally. I am purposely not going to talk about pre-exposure prophylaxis for HIV infection because you've had two really good talks about that topic in just the last 3 or 4 months. What I am going to talk about is antimicrobial resistance and Neisseria gonorrhea, HIV prevention and care, and particularly treatment as prevention, healthcare reform and its potential impact on HIV STD, and Hpv immunization, which I think is our biggest missed opportunity. Now, this slide is showing you trends in gonorrhea and pelvic inflammatory disease in the United States. And what I think you can appreciate is that PID incidence in the US peaked in the 1970s and early 1980s and then declined precipitously, reaching more or less a plateau in the early to mid-1990s. And roughly concurrent with that, we had this huge decline in pelvic inflammatory disease. So evidence that our efforts to control gonorrhea, at least in women, have enjoyed substantial success. But efforts to control gonorrhea have also always been about limited by the race against antimicrobial resistance. So the first antimicrobial used to treat gonorrhea, or effective one, was sulfonamide, developed by Gerhard Dogbeck, and you can see him receiving the Nobel Prize there. But by the late 1940s, sulfur resistance was widespread. Now, we were fortunate at that point that we had penicillin and subsequently tetracyclines. But penicillin resistance also began to develop relatively shortly after the introduction of the drug. And what we did over the ensuing 30 years was treat people with ever-increasing doses of penicillin to counter the effects of growing resistance. That worked for some time. But by the mid-1970s, we saw the emergence of plasma-mediated penicillinase-producing Neisseria gonorrhea and tetracycline resistance. And ceftriaxone supplanted penicillin as the main treatment for gonorrhea. Subsequently, quinolones and cefixime, an oral third-generation cephalosporin, were added to this STD treatment guideline. But even at the time that quinolones were added, the first cases of quinolone resistance had already been observed. And by 2007, quinolones were removed as a preferred therapy for the treatment of Neisseria gonorrhea. Now, the story of quinolone resistance is a cautionary tale. What you're seeing here is the prevalence of quinolone-resistant Neisseria gonorrhea in 1996 in Asia. And at that time, quinolone resistance in the United States was extremely unusual. But you can see that even then, more than half the isolates in the Philippines were resistant, roughly half the isolates in Cambodia were resistant, and there was a high level of resistance in Korea and China and Hong Kong already. So here you're looking at the development of decreased susceptibility or resistance to quinolones in China, the rapid emergence in the late 1990s. And this is what happened in the United States. So you see sort of this delay in the country in terms of when we got it versus where it happened in China. But it wasn't even across the country. So the first place to see quinolone resistance was Hawaii. And it was delayed roughly half a decade from what you saw in China. And subsequently, you see it emerge in San Diego. And after that, a couple years later in Seattle. And here you can see again those three cities. A little bit later in Philadelphia, it goes to the East Coast, roughly concurrently in Miami, and a few years later in Chicago. So basically what you're seeing is this pattern where the resistance starts in Asia, goes over to Hawaii, crosses to Southern California, up the I-5 corridors, Seattle, leapfrogs the country to the East Coast, and only gradually comes into the Midwest. Probably the remaining 2 cases of gonorrhea in Iowa are both sensitive to penicillin. Now what's happened? The big concern now, though, is cephalosporin resistance. And this, too, originally emerged in Japan. So the first case of resistance to oral cephalosporins was described in 2001. You can see in this slide, 1999 to 2000, there really was no resistance to oral cephalosporin. But a year later, 25% of the isolates in Central Japan were resistant. And those organisms have been sustained and are also resistant to tetracycline, penicillin, and quinolones. This shows you the current picture, or at least the picture as of 2010 in Europe, using an MIC of 0.25 to describe resistance, which was what's used in Europe. The dark gray countries are those where resistance has yet to be observed. The dark green, where it's more than 5%. The light green are less than 5%. Overall in Europe, 9% of the isolates have this elevated MICs to oral cephalosporins. But it's heterogeneous, and in a country like Austria, it's actually 22% of the isolates are already have high MICs to oral cephalosporins, the suffixing. So clearly, this microorganism, this resistance has gained a strong toehold in Europe. Now, in the United States, the situation is not quite as dire. Here, we're concentrating on the western United States, which again, as with quinolones, is the first to observe this problem. About 5% of the isolates in men who have sex with men have high levels or high MICs to suffixing. About a little over 2% in men who have sex with women as of 2011. But we're seeing this same geographic pattern, more or less replicated. So higher levels of resistance seen in Hawaii, in San Diego, somewhat lower levels of resistance elsewhere, though Portland has been an outlier. They clearly had a cluster of resistant isolates. I think the other big issue, and some of you probably already saw this this week in JAMA, there was a paper from Toronto looking at treatment failure in people who were treated with suffixing. Now, it's important to realize that these patients were either treated with suffixing monotherapy or suffixing with doxycycline overwhelmingly. But even at the MIC of 0.12, they were observing 25% treatment failure. And these are not mostly pharyngeal infections, which are harder to treat. So it may be that the numbers we've been using to define decreased susceptibility are not actually entirely right either. If you use this 0.12, overall 3% of the isolates in the United States have that level of resistance. In the West Coast, 8.5% of the MSM isolates are 1.12 or higher, 2.5% of the heterosexual isolates. Now, how about ceftriaxone? Ceftriaxone is the mainstay of therapy. It's an injectable cephalosporin. It achieves much higher levels. This is what we're relying on. This is the first-line agent for CDC. Here you're looking at intermediate susceptibility Neisseria gonorrhea in China. And unfortunately, we're seeing this dramatic rise as well. So these are not truly resistant. It's not clear what the clinical significance of these are, but the MICs are clearly going up. And if you look at Europe, and I know this is a little bit of a complex slide, but we're looking at MICs on the x-axis. If you concentrate on those last two bars, so 2009, 2010, you can see this big increase in the proportion of isolates at 0.06 or higher. So then comparing US, again, relatively protected compared to Europe and Asia. So overall, looking at these intermediate susceptibility isolates, 45% in China, 15% in Europe, 3.5% roughly in the United States. Well, how did the gonococcus do it? Well, if you think back to your college microbiology course, and some of you are much more expert, I'm sure, at this than I am, there are three mechanisms of horizontal gene transfer. So the first is conjugation, where there is a conjugation bridge is formed and extra chromosomal circular DNA is transferred from one bacteria to another. That was important in penicillinase producing Neisseria gonorrhea and high-level tetracycline resistance. Is not what's going on here, though. There's transduction through which bacteriophage, a virus-affecting bacteria, are able to introduce new genes from one bacteria to another. Again, not really the issue here. The issue is transformation, which is that the gonococcus is extremely good at the uptake of free DNA. And either from dead organisms or Neisseria actually have mechanisms through which they are able to extrude free DNA to transfer from one organism to another. So Neisseria are able to recognize a 10 base pair common motif and uptake that frequently. And that is what's been going on mostly with the gonococcus in terms of the changes in penicillin binding protein 2, which have resulted in decreased susceptibility to oral cephalosporins. Now, this was originally identified in Japan, and what they saw was this mosaic. So this would be a fully susceptible isolate. And here you see the presence of a gene in Neisseria cinceraria, another one in perflava, which are then transferred to form this mosaic gonococcus, or a mosaic Neisseria gonorrhea, which is where the resistance was observed with oral cephalosporins. Now, that's not enough to cause ceftriaxone resistance. That mosaic is enough to cause resistance to cefixime. But you have to have additional mutations to see the high MICs to ceftriaxone. But we have seen that. So these are these superbugs that maybe you guys have heard about in the media. These are rare. We have 3 reports to date. The first one was from Japan. Subsequently, 2 related microorganisms observed in Europe. A couple things to note about these. The first is that while they all had the common mosaic, they weren't the same between European and the Japanese strains. The additional mutations were different. So there's a divergence in the lineage of these microorganisms, suggesting, that what we're seeing is separate mutational events, geographically different areas, which is, I think, quite worrisome. On the other hand, everyone was cured. And I don't say that to diminish the importance of this, but just to strike the right balance between complacency and panic. That in fact, people were cured. The first person was cured with ceftriaxone. Actually, they didn't report how much ceftriaxone they gave the patient, so that's a little tough to know. Second person was cured with gentamicin. The third person actually was 2 people. One was cured with doxy, one was cured with azithromycin. So far, these in fact have been treatable, although I think it's certainly worrisome. So what are the challenges and opportunities here? Well, I think the biggest challenge is the need for a global response. I mean, at present, we don't have surveillance monitoring, although I think it's improving. That's truly global. We've had an erosion in our cultural infrastructure with the introduction of nucleic acid amplification tests. So although things have gotten better and we have seen a global response, this is going to be hard to monitor. The bigger problem is global antimicrobial stewardship. That we really have in many parts of the world, there is no legal framework even to limit my antimicrobial use. And there's no associated educational and public health infrastructure to institute that sort of thing. And it's hard to imagine how you can control a problem like this in the United States alone, or in the United States and Europe alone. We simply are not isolated. So it's like any environmental problem. We're all in this together. I think we do have some opportunities, and one of the big ones is identifying and treating the reservoir of asymptomatic infection. So we know that 30 to 40% of men who have sex with men and women who have genital tract gonorrhea are going to have concurrent pharyngeal infection. And about 8% of asymptomatic men in our clinic, our STD clinic, will have rectal or pharyngeal infection. So these are extremely common. The pharynx is relatively difficult to treat. We don't get the same antimicrobial levels in the pharynx that we would get in the genital tract. On the upside, though, we now have self-obtained nucleic acid amplification tests, which have greatly eased our ability to test people in these other anatomic sites with high sensitivity tests. And this slide is just showing you what's happened in Seattle as we've rolled this out. So the red line is urethral gonorrhea. The green one is rectal. The yellow one is pharyngeal infection. And you can see, with concerted efforts to increase the identification of these extragenital reservoirs, we've seen this massive increase in the number and proportion of gonococcal infections identified outside the genital tract, and some evidence of a concurrent decline in urethral infections, which are overwhelmingly symptomatic. So I think some evidence here, certainly not conclusive, that going after this extragenital reservoir has the potential to diminish the overall burden of infection in the population. In terms of new treatments, we use dual therapies. So the current CDC recommended therapy is ceftriaxone 250 milligrams and azithro 1 gram or doxy 100 milligrams for 7 days. Now, I don't particularly like that treatment regimen. So Lindley Barbie, these data come from Lindley, who's a fellow in our group, looking at persistent or recurrent pharyngeal infections in people treated with different regimens in the clinic. And what you can appreciate is that oral cephalosporins and azithromycin appear to be, at least historically, quite effective regimens comparable to ceftriaxone. But that doxycycline oral cephalosporins alone are associated with very high treatment failure rates. So I don't think that the recommendation to use doxycycline that CDC currently has makes sense, and that dual therapy does make sense, but it really needs to be with ceftriaxone, or with azithromycin. Genomycin, in meta-analysis, appears to be about 91% effective as a standalone drug, and that's currently being investigated in conjunction with azithromycin as an alternative agent. We also could bump the doses of the drugs we use or extend the duration of therapy with these drugs. I would sometimes argue, well, that's no permanent solution. But I don't even know what a permanent solution means to the problem of antimicrobial susceptibility. There are no permanent solutions. There are only temporary solutions. And increasing the dose of penicillin worked for 3 decades. So we can certainly bump up our dose of ceftriaxone to 1 gram, which is what they're doing in Japan. 500 milligrams is what's being used in Europe now. We could go to 2 grams. We've all given people these higher doses of antimicrobial. Ceftriaxone at 600 or 800 milligrams, given more frequently for a longer duration, appears in modeling studies that Doug Black has helped us with and that Lindley has worked on, that it probably should achieve a level that would be curative for pharyngeal infections with MICs at 0.5 or 1. We've grown used to giving people single-dose therapies for STDs, but there's no reason why you have to get a single dose. But I also think we want to think a little bit more broadly about how we're choosing our regimens and about the problem of resistance. So, traditionally we've thought about this area here of there's a difference between the minimum inhibitory concentration and the concentration you need to prevent resistance. Sometimes it's said that infectious disease doctors are doctors who figure out how much drug do I need to get to kill the bug, and we'll give them a little more. And oncologists are doctors who figure out how much do I need to kill the patient, and I'll give them a little less. And, my wife's an oncologist, and she doesn't like me to say that kind of thing. But I've come to appreciate their perspective, that maybe we're really underdosing people, and that we need to think about what is the minimum inhibitory concentration we need to prevent resistance. What is the mutation prevention concentration? And we also need to be mindful on the other side that low levels of antimicrobials promote resistance as well. So are we doing things that are leading to long periods of low-level antimicrobials, particularly in isolated anatomic sites like the oral pharynx, which are promoting resistance? Now, the other issue with resistance is we've had a tendency to concentrate on single microorganisms, and I don't think that's necessarily a good long-term perspective. So we need to be thinking about the microbiota, which is to say the collection of microbes living in a person, and the microbiome, which is the collection of genetic material that these microorganisms harbor, and the resistome, which is to say the total complement of resistance mutations that the host harbors, because clearly the microorganisms are able to share these resistance mutations. So let me switch now and talk about HIV prevention in the era of universal treatment. This slide is showing you estimated trends in HIV incidence in the United States between 1977 and 2006. And let's concentrate on the red bar, which is men who have sex with men. You can see that the epidemic in MSM peaked in the 1980s, precipitously declined with the recognition of HIV, the advent of HIV testing. and then began to gradually rise in the 1990s, roughly concurrent with the introduction of effective antiretroviral therapy. This epidemic is becoming increasingly concentrated. So here you're seeing the proportion of diagnoses in the United States occurring in men who have sex with men. And although this surveillance system has been a little bit unstable, what you can see is that the proportion of infections over the last decade in MSM has risen from 45% to 64%. And even within this, there's heterogeneity. So the proportion of infections occurring in black MSM now exceeds the proportion occurring in white MSM. So this is really extraordinary. 64% of the infections are occurring in MSM, who represent roughly 2% of the population. And a quarter of the infections are occurring in black MSM, who represent a quarter of 1% of the population. So we have an incredibly concentrated epidemic, which is becoming ever more concentrated. And where we live in Washington State, it's really concentrated in MSM, where it's almost 80% of the cases occurring in heterosexual. Now, this slide is showing you trends in HIV diagnoses and deaths associated with HIV infection in Washington State. You can appreciate, again, this huge decline in the incidence of, or in new diagnoses in the 1990s, and a rough plateauing, which I'll get back to in a little bit later. But perhaps more dramatic still, a 75% three-year decline in HIV-associated mortality. I think that probably this will be the single most dramatic change in medicine in my entire lifetime. That this bug, which when I was in medical school was essentially untreatable, and where the hospital was full of people dying of HIV infection, has been rendered completely treatable almost, and where we can tell people with newly diagnosed HIV that the reality is you will live a normal lifespan as long as you take it. So what about prevention? Well, in the 80s, I think the concentration was on basic information, education, condoms, and testing and counseling, roll-up. In the 90s, this morphed into more of counseling and behavioral interventions. And CDC put the majority of the HIV prevention money into what were called effective behavioral interventions. And these were well-studied behavioral interventions which were measured against behavioral outcomes, not against biological outcomes. The problem was their uncertain durability and the fact that they simply didn't prove to be scalable. That the cost of most of these interventions instituted in places like Seattle and San Francisco was in the $1,200 plus per person served range. And I don't think we ever got beyond about 1% to 3% coverage in high-risk populations. And it's hard to imagine that was making much of a difference. In 2003, that began to change with what was called the Advancing HIV Prevention Initiative, which began really emphasizing case finding. And that was really codified then in July of 2010 in the National AIDS Strategy, which has as its primary objectives decreasing new diagnoses, increasing access to care and optimizing health outcomes, and decreasing disparities. And at the center of this strategy is a marriage of treatment and prevention. That case finding and treatment are the dominant components of our prevention strategy. And two main innovations, I think, drove that change beyond the fact that what we were doing, I think, was recognized as not working. So the first was increasing awareness that diagnosing with people with HIV really does change their behavior. So this was a slide Gary Marks put together. At the time he did this study, 25% of Americans were thought to be of infected Americans were thought to be unaware of their infection. That's currently 21%. And those people are contributing over half of all the infections. So if we can get people diagnosed, we can really drop the overall rate of infection. Now, these data come from a mathematical model developed in our group and spearheaded by Susie Castle. And what it's showing is the estimated incidence of HIV infection versus the number of tests per year in men who have sex with men. So you're looking here at among low sexual activity MSM and high sexual activity. So this would be every 2 years in the low activity guys, every year in the higher activity sexual activity guys. And you can see if we can drive up testing frequency, we should be able to drive down incidence. I think the second main innovation was the fact that we're treating everyone for HIV. So these are as of March 2012, the HRSA guidelines are that all people infected with HIV should be treated with antiretroviral therapy. Now, the strength of that recommendation varies depending on the patient's CD4 count. Less than 350, we really have randomized controlled trial data. It's greater than 500, we're talking about more of an expert opinion. But in a place like Seattle, I think the standard of care is really that pretty much everybody is at least offered antiretroviral therapy, and overwhelmingly they're being treated. Closely associated with this change was great evidence that antiretrovirals decrease HIV transmission. So we now have 3 good observational studies in discordant heterosexual couples in a randomized controlled trial, HPTN-052, in discordant couples, that's showing that treating the infected person dramatically diminishes HIV transmission. 96% reduction in heterosexual HIV transmission if we treat the infected person. Now, I think I would point out here that none of these trials enrolled substantial numbers of men who had sex with men, that these were heterosexual trials. And so while I think it's very likely that antiretrovirals decrease HIV transmission in MSM, I don't think we can put a number to that. We simply don't have those data. Now, what that's ended up doing is refocusing prevention on what's called the care cascade. How are we doing in getting people suppressed at a population level? So these are the estimated numbers for the United States. So we have 80% of the population that's infected is diagnosed, 62% are linked to care, 41% are retaining care, and virologic suppression is 28%. So not really what we want to achieve. And this is the numbers for Seattle. Really a different story. So we think we're about 85% diagnosed, and possibly actually a little higher. 79% are linked to care, 71% retaining care, and 57% virologic suppression. So more than double that observed nationally. And I would just point out, because I know most of you guys aren't HIV people, that if we compare this to other chronic diseases, we're looking pretty good in Seattle. So diabetes in young adults, non-elderly adults, only 55% of diabetics have achieved a hemoglobin A1C less than 7. Only 47% of hypertensives are effectively treated. Only 37% of people with hypercholesterolemia are effectively treated. So relative to those chronic diseases, where we are in Seattle, actually, we're doing a little better. So let's drill down a little bit more on this cascade locally. As I said, we're about 85% diagnosed. So this is one of our big targets. Of those who are diagnosed, we actually link 93% of people to care within 3 months. We link over 95% of people to care within the first year. We have population-based partner services, people who work in our health department attempt to contact every single person newly diagnosed with HIV to ensure that they're linked to care. And we don't close their case until they do link it. So we have extremely high levels of linkage. But where things begin to fall apart are after that. So only 90% of those people are retained in care, which is to say that they've been seen at least once in the year. And of those people, only 76% have been seen twice at least 3 months apart. And that level of engagement, twice at least 3 months apart, is associated with excessive antiretroviral suppression. So our problem is more that only 80% of those people who we are retaining in care are suppressed. Where we have the big problem is inadequate engagement in care. Not so much that we don't link the patients to care, or even that we don't, in some peripheral way, keep them in care. Now, if we look at HIV testing, again, Seattle's very different than most of the country. Here we're looking at men who have sex with men. So almost half of men who have sex with men newly diagnosed with HIV infection in Seattle have tested negative within the preceding year. And only 9% have not tested ever. In the country, only a third have tested in the preceding year, and almost a third have never HIV tested. So really, again, we're different than the country as a whole. What are the factors associated with late diagnosis? Well, heterosexual HIV acquisition and female gender, African American race and Hispanic ethnicity, and closely associated with that among MSM not being out or being a non-gay identified MSM. And I think what this suggests is 2 strategies. So first, what we need to do is increase testing frequency in the population of people who are already HIV testing. And the way we propose to do that is through electronic text message reminders, which are already being rolled out to community-based organizations and which we hope will be rolling out through our STD clinic in the coming year. Through increasing testing people with bacterial STIs, which are the group at highest risk for HIV acquisition and new diagnosis. And potentially through home testing, which is something I know Joanne Steckler talked to you about when she gave her talk a couple months ago. But we also need to test people who don't currently test. And here we rely on you. We need to make HIV testing part of routine medical care. This is a grade A recommendation of U.S. Preventive Services Task Force, which means that it's going to be covered by all insurance under healthcare reform. And you do not need to do the laborious written consent forms that were done in years past. So the patients, we can do opt-out testing. Patients have a right to know that they're being tested for HIV, and they have a right to say, I don't want to be tested. But we don't need to go through the elaborate processes that were done in the past. Now, the other piece of this is about ensuring engagement in care. And what we're trying to do here is what's called the CARE and ART Promotion Program, which has been spearheaded by Julie Dombrowski, who's an assistant professor of medicine in our division. And we're using the surveillance data to identify everybody who doesn't have evidence of engagement with care via labs in the preceding year, or who have CD4 counts greater than 500 and a detectable viral load. We're contacting those people to identify why are they not adequately engaged in care, and to try to develop with them, their medical providers and their caseworkers, a plan to increase their use of antiretrovirals and their engagement with care. So our initial foray into this, it's a little tough to know. We're just getting started. We've completed this effort in about 350 people. About 2/3 of the people we've tried to contact, we couldn't get to participate. So we didn't have response from a lot of people. We still have a fair amount of provider refusal. But I would say that having done similar things like this in the past, the provider refusal, I think, will evaporate over time as the providers get used to this. But I think it really, we need your help. Now, the last thing I want to show you is we are making progress. So what you're looking at here is trends in deaths associated in people living with HIV in King County and HIV diagnoses over the last decade. And we've had almost a 1/3 reduction in deaths in people living with HIV over the last 10 years, and a 27% reduction in HIV diagnoses in King County over the last 10 years. So we are seeing progress. It may not be everything we want, but it's not nothing either. So what are our implications? Well, I think that treatment is among the most effective interventions in all of medicine, maybe the most effective, other than perhaps vaccines and some surgery. We're effectively treating a large and growing proportion of people, particularly locally, and I think that this is our best opportunity in prevention. At the same time, too many people are testing late, and it may be that testing and ART are not enough. We haven't really proved this, and so we need to be mindful that we continue to promote condoms and continue to promote safer sex. But I think more broadly what this suggests is a different sort of relationship between us as providers and between public health and the provider community. You know, Ginny Brody, as we've changed how we run the residency program, has impressed on me that we've moved from a system where it's your patient and you're going to be responsible by yourself, working 36-hour shifts on the wards as an intern or resident, to a system where we're going to have to work together. And the characteristic of a successful system is collaboration and fail-safes and redundant fail-safes. And part of this is a new relationship between public health and community providers where we're all engaged in the control of chronic diseases. And I think the model that we're taking with HIV is potentially a model for a wide spectrum of chronic diseases in terms of surveillance and outreach. So I think that segues well into healthcare reform. This slide is showing you what Washington State is estimating will be the post-implementation of the Affordable Care Act subsidized coverage in our state. We currently have 1.16 million people who are enrolled in Medicaid. And with the rollout, and we have another over 500,000 people who are eligible but not currently enrolled, about 75,000 of whom, or 78,000 of whom, we anticipate will enroll in Medicaid with the rollout of the ACA. We have another roughly 500,000 people who are going to be newly eligible for Medicaid through the Medicaid expansion. Remember, two main parts of this reform: the expansion of Medicaid and the exchanges with subsidized insurance. And we have another a little over 500,000 people who are going to be eligible for subsidies through these new insurance exchanges. So a big number of people in Washington State are going to get new access to health insurance, which is, I think, a huge win. At the same time, for HIV, it may be a little bit more complicated. So the way the system currently works is it is largely or very substantially financed through a program called Ryan White, which is an over $3 billion federal program which provides medical services and support services to persons living with HIV/AIDS. And in our state, what that mostly means is that the program buys people health insurance. It pays for medication, it pays for case management, it pays for mental health, some housing, some drug treatment, some nutrition, a variety of other support services. So in many ways, HIV was given this unique status of all chronic diseases with a carve-out, or perhaps not entirely unique, but somewhat unique. And in Seattle, about 40%, a little over 40% of people living with HIV infection are receiving their medical care through Ryan White funding. We have no waiting list for medication, and our model is one which, for the most part, involves HIV specialists being primary care providers. Well, this is what we think roughly is going to happen. So again, Medicaid expansion is going to go to 138% of the federal poverty level, and from 138% of federal poverty to 400% of poverty, people will be eligible for subsidies on an insurance exchange with higher levels of subsidy for those with lower income. We're going to move from a system where 42% of the people are funded through Ryan White for their medical care to a system where that is mostly gone except for potentially people who are undocumented and maybe a few other small groups. We're going to expand the people who are on Medicaid to almost half. And that other 40%, and 40% are going to be funded through insurance, much of it through these health insurance exchanges. Well, I think that poses some potential challenges to us because we're starting with a system which is at some level is the Cadillac, at least relative to other states. So in terms of case management, which most of us who do HIV care feel has really been a central part of our success and is very important. We're starting out with a system where if you're less than 300% of federal poverty level, you're eligible for case management through Ryan White. We're going to move to a system where if you're 138 or less through Medicaid, you will likely be able to get this through the health home. Now, that's not 100% nailed down, but Sebelius, the director of Health and Human Services, is supportive of this. The state has been supportive of this. I think this is likely to go through. But if you're over that and less than 300%, remember those people previously have been covered, it's not clear how you're going to get your case management services. So is Ryan White going to pay for that? Will this be an essential health benefit on the exchange? It's not entirely certain. Now, more important still, I think, is the medication. So right now, less than 300% of poverty, you are getting your medication with copay support. Under the new system, you're less than 138% of federal poverty, you're on Medicaid, you're going to get your medications. But above that, through the exchange, you're probably going to have copays as things currently stand. And depending on the size of those copays, that could be a major impediment to treating the population at the level we're currently treating them, unless we can come up with a way to deal with that problem, which is potentially doable, but it's not necessarily, it's not a foregone conclusion. And the last is the source of care. So again, our system is really built on HIV specialists providing primary care in places like Madison Clinic. Madison Clinic cares for roughly a third of the people living with HIV. Well, with the shift from purchased insurance by Ryan White to Medicaid, there probably will be some decrement in the compensation. Will that drive patients, particularly from the private providers, into other care sources? And will it diminish compensation at Madison and potentially undermine our current care model? Now, what's been proposed is what we want to move people into these FQHCs, these federally qualified health centers. But we don't have an FQHC infrastructure where we live, which is well poised to do this. Moreover, given the fact that we have what appears to be the highest level of viral suppression of any city in the United States, it's not entirely clear why we would want to adopt a different model of uncertain effectiveness compared to what we currently have. Now, for STIs other than HIV, there are also potential vulnerabilities. So the upside is we're going to expand insurance. And the new system is going to cover you for grade A U.S. Preventive Services Task Force recommended intervention. So that's going to include HIV testing, chlamydial testing. And it is an opportunity to expand coverage, and I think there's a lot of opportunities there. At the same time, it's a potential threat to our traditional infrastructure, which has relied to some extent on sexually transmitted disease clinics. And those clinics are closing all over the United States. At this point, the STD clinic at Harborview is the last true STD clinic in the state of Washington. The other ones are all gone. Well, how important are these clinics? Well, I think they're pretty important. So this is showing you in the red bars, in a non-systematic sample of US cities, what proportion of different STD diagnoses are made in these clinics, and in the blue bar, Seattle. So across these sites, 15% of all diagnoses were made in STD clinics. In Seattle, it's over 1 in 5 are made in the STD clinic. Roughly a third of the cases of syphilis, a quarter to a third of all gonorrhea diagnoses are made in these clinics. A much smaller proportion of people with familial infection. Really, the STD clinics are not critical to control of familial infection. And these clinics probably provide a higher standard of care than what's typically seen in primary care sites. And it pains me to say that, and probably it pains you more to hear it. But if you look at the proportion of people with gonorrhea in Washington State who were tested for HIV, and if anybody in this world should be tested for HIV, it's a man heterosexual man who has gonorrhea. The possible only other group that would be a higher risk would be syphilis. You can see outside STD clinics, only about half are getting HIV tested, much higher in STD clinics. And the same would be true of other risk groups. And the proportion receiving ceftriaxone, which is our recommended therapy, significantly higher nationally in STD clinics than would be seen in other sites. The patients also want to go to STD clinics. So in this study, and this is, I grant you, a few years old, people leaving STD clinics were asked, well, if medical care were free, where would you have gone for your STD care, your STD services? 68% said, no, I still would have gone to the STD clinic. And actually, the people who were insured were more likely to say that, not less likely to say that. Massachusetts is a state which essentially has universal health insurance. 98% of the population is insured. But when they look at their STD clinics, only 71% of that population is insured. And the reason they're not insured are things like I lost my job, I couldn't afford the COBRA, I'm unemployed, I can't afford it, I'm employed but I can't afford it, I'm ineligible for a subsidy. And I think it just points to the fact that this is really going to be important. It's not going to completely eliminate the need for safety net providers. And even among the people who were insured, most of them didn't want to use their insurance. And the reason they didn't want to use their insurance mostly had to do actually with confidentiality. That they preferred to compartmentalize their sexual health care. So, you know, the rationale for these clinics is that they're a critical source of care for the highest risk populations, that the quality of care is probably better, that the patients want it, and that we're still going to have a need for a safety net. That these play a central role in public health and research. And the experience in other high-income countries is that you need these. So the United Kingdom, Canada, the Netherlands, Sweden, Australia have all had nationalized health care for decades and all have elected to maintain this infrastructure. And the notion that we won't need it, but everybody else is wrong, strikes me as really foolish. So the last thing I want to talk about is Hpv immunization. And what you're seeing here is the person years of life lost from different cancers. And you can, not surprisingly, lung and breast and colon are the big ones. And cervical cancer is way down. But if you look at the proportion, or the average years of life lost per person dying, the only cancers which cause more are childhood malignancies and testicular cancer. So cervical cancer is different. It affects people in the prime of their life, and it removes a huge part of their life. And I think if you have a sense of social justice, you have to feel it's different for somebody to lose 25 years of their life than a couple years of their life. So it is important. We have a great intervention. We have an immunization which is 99% effective against HPV 16 and 18. But our experience, again, is a cautionary tale. So if you look, our first STD vaccine was hepatitis B. We just didn't sell it as an STD vaccine. The vaccine was developed in 81. 10 years later, ACIP recommended universal immunization. 16 years later, we had what's called a school mandate. And in 2004, 23 years into it, we had managed to vaccinate 58% of the 18 to 20-year-olds. So, not what we're looking to replicate. Well, how are we doing? Well, 35% of girls at this point nationally have received the 3 doses. Washington's 40%. We're not seeing a steep increase on this. We're seeing a gradual increase. Interesting that pneumococcal vaccine or meningococcal vaccine seems to be so much better, which is also an adolescent immunization. But not everybody is failing. So these data come from Australia. By 2009, 71% of adolescent girls had already been immunized. And this is showing you the percentage of people in their STD clinic with warts in Melbourne. Warts essentially disappeared from Melbourne with the introduction of HPV vaccine. So early evidence of a huge population level effect with the effective introduction of this vaccine. Well, what if we just replicate the kinds of things we've done? And I want to point out Australia's school-based immunization, the tried and true. We know it works. There is no question. Well, if we waited 15 years, then we're going to accept 20,000 avertable deaths and over 500,000 years of life lost. And, you know, this is shameful that we would accept this. So this is the biggest missed opportunity in my field, I would say. So in conclusion, I'd say HIV testing and treatment are the cornerstones of prevention, and we're making progress. But that further progress is going to require a new model of care that's going to include systematic efforts to ensure sustained engagement and new collaborations between public health and medical providers. I think the ACA is a huge advance and will improve the care of Americans, but it poses risks, at least in the area of HIV-STI. Antimicrobial resistant Neisseria gonorrhea is an emerging global threat, and it's going to require big scientific, clinical, and public health innovations. And our progress in instituting Hpv immunization represents a critical, correctable failure. So thank you for your attention, and I'd be happy to try to answer questions.